Good afternoon, everybody. Before we begin, I would like to let everyone know that this session is being recorded. These recordings will become available on our DentEcho website after a session. Julio, could you please share the announcement, housekeeping slides? Thank you. Thank you. We are very excited to have all of you join us for the 22nd DentEcho. This session is brought to you by the UT Health San Antonio School of Dentistry. I'm Kato, and I will assist in facilitating today's session. Next slide. And here's our agenda for today. We'll start off with some announcements and introductions, then move on to didactic and case presentation by Dr. K, with time for Q&A at the end. Next slide. And some notes before we get started. These sessions are recorded for later distribution on our DentEcho website. Please stay muted unless you are speaking. You can also use the chat to raise questions and share your perspectives. The slides and recording will be made available on our DentEcho website after session. And to help us with attendance, please enter your name, affiliation, and email into the chat. And please remember that no personal health information is allowed in either the chat or our discussions. And if you would like assistance with your connection throughout the session, please chat Julio, our DentEcho IT for today. Next slide. And for those who may be new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions include a didactic presentation and de-identified case-based learning and group discussion to foster deep knowledge and build individual capacity. ECHO is an all-teach, all-learn supported model, and ECHOs thrive on the interaction from the full learning network. So we encourage everybody to participate in the conversation today. And we also encourage you to join by video if you can. And next slide. And we offer CDE credits. To receive credits, please make sure to be on the session throughout the duration of the presentation. If you would like to receive CDE credits, make sure to register through Smile, which you can do so now using the link in the chat or by scanning the QR code. And when registering, please use the super code ECHO 2024. And thank you, Julio. Please unshare the slides. All right, perfect. And with that, we'll move on to introductions. Well, today, from the Hub team, we have Kathleen, Dr. Dar, and Dr. Chala. And I will pass the mic over to Dr. Chala to introduce today's speaker, Dr. K.
Thank you, Kito. Welcome. I'm Suman Chala. I'm Associate Dean for Advanced Education Programs and also the Principal Investigator for this grant that supports DentEcho. And I'm delighted to introduce Dr. Maria Karatsikagoulou. She comes from Greece, and she's also a proud graduate of our dental program, orthodontic program in our school. And she's an ABO certified orthodontist and also the program director of our orthodontic residency program. And she's also the president of the American Lingual Orthodontic Association, along with being the current president of the San Antonio chapter of the IADR as well. Her expertise includes managing patients with complex craniofacial anomalies, utilizing 3D printing technologies and clear aligner treatments. So we're delighted to have her here and pass it back to Kito.
Thank you so much, Dr. Chala. Dr. K, please take whenever. Thank you so much. Right.
Thank you so much for the wonderful introduction, Dr. Chala. I want to start by thanking the whole DentEcho team for, first of all, doing me the honor of being a speaker for this wonderful program, but also for the contribution you're doing in the Dental Society, keeping us informed and educated. I'm very happy to participate. Despite Dr. Chala pronounced my name perfectly, my last name, I know I have a very long last name. So everyone calls me by Dr. K, but just want to clarify, my name is not the longest one in the history of Greek names. So there's actually one with 37 letters. So we're good. So as Dr. Chala said, I'm from Greece. Greece is a very small country. I was born and raised there. And Greece is I don't know how many of you are joining us from Texas, but it's 7 times smaller than Texas. However, it has lots of beauties, and I sincerely invite everyone to visit it at some time. That's where I completed my dental studies there. And then I had the honor to come here to the US and meet my second family, which is the Utesca family in UT Health San Antonio. And later I was given the opportunity to be appointed as the program director of the residency program. So I really love UT Health San Antonio, and I feel extremely lucky to be part of this wonderful team. So today I would like to talk about congenitally missing teeth, and mostly in growing patients. This is one of the challenges that we face in our practices, because it's one of those cases that there's only few things we can do to permanently restore the patient's problem with a solution that doesn't have any shortcomings. I will discuss in detail on this first segment of the presentations what are the available options that we have, but truth is, on a growing patients, permanent restoration of those missing teeth is quite challenging. So first, I would like to start with a review of the literature. And I just want to say anytime anyone wants to jump in and ask any questions, provide further insights, or ask for clarification, please go ahead and do it. I want this to be as interactive as a virtual lecture can be. So looking at the literature, and today we're going to focus mostly on congenitally missing premolars, because this is one of the two groups that are most frequently missing if we don't count the wisdom teeth. So lateral incisors and second premolars are the two most frequently missing permanent teeth. So, of course, implant restoration is always there as an option. The challenge is, again, we have growing patients. And in the following slides, we are going to discuss a little bit about why placing an implant on a growing individual, even if it seems that their growth is complete, might end up being extremely problematic. And then, of course, primary teeth could also be maintained. And we will see the prognosis of those teeth when they are maintained. However, we want to ensure that they don't have any resorption. The interesting part with primary molars is that their mesiodistal dimension, it's quite larger than the premolar that's coming underneath. So as you see on the top right, this is a clinical example where they're trying to resolve this by performing hemisection or a trimming, interproximal trimming of the tooth to try to make it match. And that is because if we keep the molar there, in most instances, we were not going to be able to have a class 1 occlusion, or even if we do, we probably will have a midline discrepancy since we have more tooth mass on one side of the mouth than the other. So there are definitely challenges. So we're going to discuss a little bit about the hemisection. And then even if the primary tooth needs to be extracted, we still have the option to try and maintain the space to restore later on when growth is complete with an implant. However, all of us here know the consequences with edentulous spaces over many years and the loss of alveolar bone. So we are going to discuss a little bit about that as well. And then ideally, one thing that orthodontists like to do a lot is when a tooth is missing, close the space. And in cases that that's possible, that in my opinion is the ideal solution, but that's not always possible. The occlusion does not always allow us to move molars forward and distally as much as we want. And then the largest part of my presentation today is going to be on autotransplantation, which is the treatment modality I will be presenting. First, the literature aspect of it, but then we're going to see some clinical applications of it. So starting with the early implant placement in growing patients, there have been a lot of studies that attempted to place permanent implants even on 10 or 11 years old. And growth is a significant factor in the timing of implant placement because the implants are basically operating like ankylosed teeth. And whenever we see ankylosed teeth in a growing patient, we immediately extract them. So the dental implants are not capable of following the growth of the jaws or the continuous eruption of the adjacent teeth. So what happens is, most of the times, more frequently than not, even in patients of 18 or 19 years old, the late mandibular growth, the vertical mandibular growth manifests as an implant infraposition, meaning all the rest of the teeth are extruding and this tooth remains stable. And as I said, considerable infraocclusion, as proven by this wonderful research done by Dr. Papageorgiou, which means more than 1 millimeter, is observed in over half of the cases. And then the rate may be as much as 0.8 millimeters per year. Now, going to a clinical example, this is one of my patients where we optimized the space. That was an avulsed central incisor on a 14-year-old, that we optimized the space for implant placement. And then once I referred, in the end of the treatment, I like to refer to the restorative dentist or the general dentist to let me know if we have adequate space for me to remove the brackets and move on to the retention. In this case, the referral came back with the suggestion of placing an implant there, a permanent implant that would have been viewed as a semi-permanent solution, just so the patient has something fixed there. And then eventually remove the crowns to address the infraocclusion, and then eventually remove the whole implant. And while in some cases that might be the right approach to provide the patient with a fixed restoration, it is very risky. And the biggest risk is if the patient has significant excessive vertical growth, which on a male of 14 years old, we traditionally expect. So not only the bone that was there is not going to be maintained, we're taking the risk of creating a significant bone defect there that it becomes non-restorable even later on with bone grafting. However, that does not mean that if the patient insists, there's not any way for them to provide them with a fixed restoration. And that is a suggested treatment protocol that is very innovative and has been applied multiple times. Instead of regular dental implants, the orthodontic mini anchorage TADs, the temporary anchorage devices, are being used. And the key point here is that this implant is not placed vertically on the alveolar ridge, but transversely. So for this patient that was missing a lateral, the TAD, the skeletal anchorage device, is placed transversely on the ridge, and then they attach a temporary Pontic on it. The key for this technique is to get bicortical engagement. So both the lingual and the buccal cortical bone need to be engaged. And in that case, it has been shown through this research that the vibration and the occlusal function promote the vertical growth of the bone coronally to the mini implant. So this is actually a very good option to not only have maintained the bone, but also have a vertical implant side development. From my personal experience with those, I've seen that even though in theory they're fantastic, they're sometimes quite challenging in terms of stability and emergencies. So these do tend to break, or the implants may fail. And then in the intermediate, until another implant can be placed, we do tend to have some relapse. So it is definitely a great option as long as the clinician is prepared to be able to address all the challenges that come with this system. And now moving on to the second modality, the primary tooth can also stay there. And then research shows that it might stay there even 40 to 60 years, more than any restoration we could have done otherwise. As I mentioned before, though, the primary molars tend to have very divergent roots. So even if we go ahead and do the interproximal trimming that we saw in the one of the initial slides, that we might still not be able to make these teeth come closer to each other. When we see this root divergence, but we have excellent roots on the primary tooth, we still may elect to keep this tooth for as long as possible, as long as the patient understands that if the tooth fails, they will have to have some limited orthodontic treatment there to optimize the space for a premolar. In some cases, the average time that this molar remains there, the physiologic root resorption that happens on those primary teeth without any permanent tooth coming underneath is around 10 years. So 10 years would be a significant gain until a patient is ready to get their implant placed. However, we're not always lucky to have good and nicely behaving primary molars. Quite frequently, it's quite common for those primary molars to be ankylosed. And when they become ankylosed, they're equally as bad as any implant that could be there. As a matter of fact, if you see on the upper left, where there's this area of a defect mesial to the molar, there's a primary tooth there. There's a primary first molar that has been so ankylosed for so many years that has been secondarily re-impacted in the gingival tissues, and the bone is not developing on that area. I have some x-rays to show you later on in the presentation. So, on those cases that we have ankylosis of molars, then the only solution is extraction. We cannot delay, and then, as is shown with this very heroic treatment plan, an orthodontist who published this article can attempt to bring the other teeth forward, however, with great risk of moving this teeth into a bone defect. In this case, the bone moved along with the teeth, and it was an excellent result. That, however, took a very long time. And then the other option would be to just remove the tooth if it's ankylosed and maintain the space for a future implant. And implants have an increased cost, but more than that is the biological cost of losing the alveolar ridge. This is a patient that had their molars extracted when they were 7. And the first time I was able to take those x-rays was when they were 11. So just in that amount of time, you can see how much ridge resorption we have. And I would say for this patient to get an implant placement in 80 years minimum after this time point, it would be extremely challenging, if not impossible. And with very expensive ridge augmentation techniques. And another thing is that when we're done with treatment so early, if you ask any patient, not just those patients, to wear a retainer every day and every night for the next, let's say, 9 or 10 years, chances are they're not going to do that. They're going to lose it, they're going to misplace it, or they're just not going to be compliant. At least, unfortunately, the majority of patients. So in those cases that we cannot really use a fixed retainer there with much convenience, you're running the risk of complete relapse, and then the patient again has to go through treatment to recreate the restorative space. And then, as I said, space closure would be the ideal solution. As we did in this case where the primary teeth were resorbed, they had crowns on them, and then most importantly, the patient had crowding. They had so much crowding that we were able to utilize the space for the primary teeth to align the crowding and then protract the molars. What's key on those cases is for the patient to have their wisdom teeth, the lower third molars, and ensure they're not going to extract them, because these teeth are going to erupt as normal, and they are going to occlude with the unopposed upper second molars. So in order to the upper second molars to be in normal occlusion, I cannot emphasize enough that these wisdom teeth need to remain there. So we let our patients know not to extract those teeth. If the patient doesn't have crowding, then it means that the whole space needs to be consolidated by protracting all posterior teeth. And that is extremely challenging. There are some techniques that can be applied to expedite, like corticotomies or skeletal anchorage techniques, that we can protract those molars. However, the time is pretty long, and those treatments are usually very long. We're risking root resorption on the molars. So it's overall recommended only for patients that we need the front teeth to come backwards, which is a much simpler movement than the back teeth coming forward. But as I said, it can definitely happen even in adult patients. And then going to our topic, there is a definitely underutilized and highly successful treatment modality that we can utilize, which is autotransplantation of the teeth. As it is defined by literature, it is a surgical procedure where the tooth is extracted from one location of the mouth and then repositioned to another one. In the past, it has been mostly used to replace avulsed central incisors or traumatized central incisors, and they utilize usually a premolar or a molar that's then prepped to look like an incisor, but it has been also used to replace congenitally missing teeth. And the key for this modality is that once the tooth is transplanted, it can develop as normal in the growing patient. It will erupt, and then it's gonna react like a normal tooth. All the physiologic reaction of the tooth are as normal. So why did I say it's underutilized? It's because the success rates of this procedure are extremely high. So this is a set of studies done by Dr. Adrensen in Copenhagen, Denmark. And they were a while ago, but their cohort was quite large. And their success rate, even though they were not using the most updated surgical techniques that we now use with 3D planning, the success rate, the survival of those teeth was 99%, meaning after 10 years, only 3 of those teeth were extracted. Now, how do we define success and how do we define survival on autotransplanted cases? When a donor tooth is moved, 2 main things can happen. You can have ankylosis or you can have external root resorption. In cases of ankylosis, these teeth need to be extracted. In case of external root resorption, these teeth are usually treated with endodontic treatment, and then the progression of the disease is arrested, and usually they can remain in the mouth. So as success rate, we define the teeth that did not need any endodontic treatment and they were not ankylosed. Success rate means a tooth where it reacts in the mouth like a normal tooth. The donor tooth was completely accepted by the oral cavity. The survival rate includes those teeth that had root canals done. However, they are still able to be there like a normal teeth. So in a more recent systematic review, the overall success rate was again close to 90%. And then the survival rate, meaning the teeth were not extracted despite maybe having root canals, was 98.2%. So for me, I think those numbers speak quite loudly, especially in cases that we are already extracting teeth for other sides in the mouth. It's definitely at least an attempt, since the alternatives that we just presented may not be that ideal. So what are the critical factors for autotransplantation success? First of all, timing is important, and the level of root formation to ensure pulp healing and favorable root to crown ratio. So we do want the root to be at least half its length, more than 3/4. We want the apex to be at least 1 millimeter wide. And that is because we do want the tooth to be able to revascularize. So we do want to do it when the apex is open. However, that does not mean that we cannot do it after the apex is closed. In those cases, all that needs to happen is for a root canal to happen 2 weeks post-surgically. On the other hand, we don't want to do it too early because it's highly likely that the root development, even if the tooth reacts as normal, the root development is not going to continue for much longer after the procedure. So we do want at the point of transplantation to have a good root to crown ratio, even if the root development is arrested there and the root we have apexification at that point. And then the other two critical factors is for us to maintain the follicle intact, because the cells on the PDL are the ones that are gonna ensure the osseointegration of the donor tooth, and then minimize the extraalveolar period less than 1 millimeter, less than 1 minute extraorally. So how do we manage to do that nowadays? Back in the day, they used to use the donor tooth, the extracted tooth, and they used it as a guide to prep the socket like we do in implants, and they were using the actual tooth, and that resulted in traumatizing the PDL and having high rates of ankylosis. Nowadays, we use the CBCT and we print or through metal, as it was done in this article, a replica of the tooth that we want to transplant. And then we use that as a guide to prep the socket so the recipient side is ready to accept the donor tooth before we even attempt the extraction. And then when it's time for the extraction, the tooth just spends less than 1 minute outside the alveolars. And this is an example of ankylosed maxillary incisor that was then a premolar was transplanted in that area. And then you can see the result over here. So this is from Anderson articles demonstrating how the root development should be for a success in autotransplantation. And the surgical procedure, as I mentioned, for the 3D replica is fabricated and it's used to prepare the socket. And then it's fit. Once it fits and the socket is ready, we go ahead and do an as atraumatic as possible extraction of the donor tooth. It's implanted and sutured infraocclusally to make sure we're not going to have any occlusal load, but we also leave enough space for the tooth to express its eruption potential as the apex forms. So that was the didactic part, and we can move forward to the case presentation, right? We're good to go. Awesome.
Yes.
So this is a case of a patient, a 11-year-old female that just came in because she wanted straight teeth. And she didn't have any contributory medical or dental history. And everything upon clinical examination, both extraoral and intraoral, was pretty normal for her age. So nothing significant. Yes, we did have a bit of a deep curvus P, but overall we had quite normal and a little bit of extra overjet. However, looking at the lateral side, we identify the first main issue that we have with this patient, and it is the fact that we have a molar that is class 2 relationship. On the left side, everything looked as normal. Now, looking further into this class 2 molar, from the occlusal aspect, we can see that because of early loss of the primary molar in that quadrant, that molar has drifted forward, the first molar has drifted forward, and now we do not have enough space to align tooth number 4, 5, and 6. On the lower, as I said, things are looking still pretty normal. And then looking at cephalometric radiograph, we can see that the patient has a slightly retrognathing mandible, meaning there's a small difference between the top and the bottom jaws. So now looking at the panoramic X-ray, we can see a lot of things happening. So I'm going to take the analysis in quadrants, and we can rest assured that in the lower left quadrant, everything looks normal, as we would expect in a patient this age. However, moving to the top right quadrant, Here we can see the radiographic representation of the problem that we saw clinically, meaning that between the molar and the lateral, we don't have adequate space to fit the canine and the two premolars. And in that case, we have two options. The first option would be to distalize, like we see in the clinical example on the bottom left. So it would be restoring the problem, pushing the molar back. However, that would significantly increase the potential of that second molar being impacted. Also, it's not a very stable treatment, and then in case we need to use skeletal anchorage to achieve it, there's also a higher cost associated with it. The other option, and probably simpler, is to continue what nature was planning to do. Remove the tooth that's not fitting, that's impacted, and then just move that molar forward and close the space. It will take less time, it's more simple, and then we will definitely have space for the second molar eruption. And we don't really need the compliance of the patient since it's a straightforward treatment. However, we are losing a tooth. Now, looking at the X-ray again, and looking at the other quadrant, we can see that the patient is missing number 13 as well, the other second molar. So that brings us to the conclusion that it would probably be wiser to treat this as a two bicuspid extraction case, remove the impacted tooth on the right quadrant, and then remove the primary tooth on the left quadrant and consolidate the spaces, which, considering how the patient also have a skeletal class 2 discrepancy, it would make perfect sense. And in that case, moving to the lower right quadrant, where we're missing number 29, if we look to the discussion we have on the first segment of the presentation, we cannot really retain this tooth because it has root resorption. If we extract and close the space, this is one of those cases that is not ideal because the patient does not have any crowding and everything would move towards that side of the mouth. And maintaining the space, which was an option that was proposed to the patients, they could not afford the cost of a future implant, and they really requested for us to offer any other alternative solution. And also, you're running the risk of over extruding the teeth and everything that we just discussed as the limitation of retaining the space. So, since we have one extra tooth on the top that we're going to extract, we've decided to moving that tooth to replace the congenitally missing tooth and perform an autotransplantation. While we're trying to figure out the timing of the treatment, of course, a CBCT was used, and it was determined that that tooth is slightly less than half of the root formation. However, by the time we would take to align and prepare the patient for the autotransplantation procedure, make enough space, then we would expect that the root formation would be an adequate size for us to move forward with it. And that's what happened. Here, what you see on the left, these are wonderful guides designed and printed by Dr. Satoru Kataoka. The left is the tooth replica, and the right is a surgical guide to use as a reference in order to attempt and extract the impacted donor tooth as traumatically as possible. So it's transparent and it guides the surgeons into the ideal access point to perform the autotransplantation. And these are the replicas. This is when the tooth was extracted, the primary tooth. And then this was the socket immediately after the extractions. And it was prepared like an implant space, exactly like an implant space. And then the replica fitting was performed. This is the guide that was used here for the extraction in the maxilla. And this is the first time we saw our donor tooth. And I have a short video here to demonstrate the technique of the extraction. As you can see, they're limiting the movements just on the crown, not moving towards the root or touching the PDL. And then the transplantation to demonstrate the extra-alveolar time that is minimized. Basically, the extra-alveolar time was enough for me to just snap a picture, and then they just placed it in. So this was immediately after the transplantation. And then, as I said, we suture it infraocclusally so we can let the tooth erupt naturally. That's the sutures immediately post-op. And this was the 1-week follow-up where healing was observed and it was normal. And then we can already see on the 1-month follow-up that we have normal eruption of the tooth. Here, an excellent healing despite the patient's poor oral hygiene. At the 4-month follow-up, I started getting a bit concerned about the potential of ankylosis, and I wanted to confirm by putting brackets. Now, once orthodontic forces applies on the teeth, we expect that the root formation is going to be arrested, and then we're going to see apexification at that length. But I did consider that length adequate for me to proceed and confirm that the tooth is not ankylosed. Thankfully, we had no signs of ankylosis and this tooth moved and aligned. So at that point, we had requested the patient to go and have the other primary tooth extracted on the upper left. However, due to financial constraints and the COVID-19 outbreak, they were not able to do that until much later. And at that point, I could definitely see signs of ankylosis of the second molar on the left side. However, we tried to close the space as fast as possible with a loop. But then after a while, even 22 months in treatment, I didn't see that second molar erupting despite the laterals at the other side erupting. 20 months post operation, that tooth was, the transplanted tooth was already looking great. We had a good crown to root ratio. But that tooth remained, had difficulties erupting. So we just did some minor gingival removal to help it out. And then it finally erupted. This is an overview of the movements, both the space closure and here we have the transplantation composite. And this is the final result of the patient. It was 2.5 years, unfortunately, but it was mostly attributed to that second molar not erupting in time. And then we can see here, I always like to look at the morphology of this what's now the lower right premolar and think that it is an upper premolar. And this is the radiographic progress here. We can see the primary tooth, and this is the final. Initially, I was quite disappointed because it did look that the root is shorter than I would like. But then I realized that this is an upper premolar. An upper premolar root length, if we look on the maxilla, is much shorter. So to be honest, I don't think we got arrested root development or root resorption. It's just the morphology of the tooth. It just has a shorter root than lower premolars. And then this is the 3-year follow-up. Patient doesn't have any symptoms, and this tooth is reacting as normal to vitality tests. Now, closing up, I would like to add a couple of more clinical scenarios, but they're going to be way more summarized than the initial ones because I do want to have enough time for discussion and questions. So this is the case we saw earlier with the ankylosed primary teeth. So if we see on this x-ray, the patient has 4 premolars on the left side of the mouth and no premolars on the right side of the mouth. So she's congenitally missing all of her right premolars, maxillary and mandibular. In this case, and the primary teeth have to be extracted because of the ankylosis. This patient is 11 years old. She's very young and she already has bone defects. We can see the intraoral pictures. Here you can see the secondary impaction of this primary ankylosed tooth on the left. And then you can see the occlusal discrepancy that we have. On the right side, things are looking a little bit more normal. So what we decided is to grab 2 premolars from one side of the mouth and transplant them on the other side of the mouth. The challenging part was the top right ankylosed tooth because of the lack of bone around it and the proximity to the sinus. However, we discussed and planned very carefully with our surgeons. So this was the attempted plan, and then we would treat this as a 4 premolar extraction case, where we would have 1 premolar on each side of the mouth. So this was the removal of the primary teeth. In this case, we adjusted the replica to have a handle, just so we can manipulate it better a little bit in the surgery. And then the replica fitting. This was the infraocclusally placed upper premolar, and that was the fitting of the lower premolar, the fit. And this was 2 weeks post-implantation. To be honest, I was a bit concerned about the upper right. However, we were patient. I did apply the orthodontic forces again in an attempt to extrude it as much as possible, and it did react positively. So thankfully, just 4 months, now we are 4 months post-op, and healing seems to be as expected on both teeth. This is the progress of the maxillary one. And this is the progress of the mandibular one, which I'm not concerned about at all. And then one more that unfortunately I don't have clinical pictures for, but I just want to explain this is a new modality we're exploring, which is transplanting impacted canines that could not be aligned orthodontically when the primary canine is already retained. In this case, aligning this canine with orthodontic means, with orthodontic movement, not only would take probably 6 years, it would also completely annihilate the roots of the incisors in its path of alignment. In this case, this canine would be extracted, and the patient would have had to have an implant on that primary tooth. So I don't think if there's any harm on attempting to transplant it, especially since the timing seems to be correct for revascularization of this tooth. And I think we are on time. Thank you so much for your attention, and I'm open to any questions.
Thank you so much, Dr. K. That was very informative and a lot of images. Thank you. Does anybody have any questions for Dr. K? And I see in the comments.
I can see
yeah.
one in the comments that by Tracy Cohen that says if this procedure by done with orthodontics or something, we would collaborate on the case with a periodontist. In here our team consists of the oral surgeons, the oral surgery department. Even though we've collaborated in the past with periodontists, I would say any surgeon and periodontist would be great. We don't do it. Orthodontists don't do it. We just move the teeth and plan for it. As long as they understand and they're experienced in the handling of the periodontium and preserving the PDL. But I've worked successfully with both periodontists and oral surgeons, and it's really good to have an endodontist on the loop for vitality tests, and then be able to intervene immediately in signs of external root resorption, or in cases that the pulp necrosis because the pulp didn't revascularize.
Thank you for that question, Tracy. Thank you. Any other questions? Feel free to type it in the chat. I have a question, Dr. K. How frequently do you perform these procedures?
It's not very frequent because as I said, if we can close the space, we will. And most of the times we are able to. However, these cases tend to present themselves in a way that it makes complete sense for this procedure to happen. And then even if the tooth fails, you can still proceed with your original plan of preserving the space for implant or closing the space. especially in cases that you do want to attempt to close the space, but it's not ideal. You're going to struggle. Attempting the autotransplantation procedure is a surgical operation there that reacts quite similarly to the corticotomies, the other modality that I describe as helping the molars come forward faster. So even if that fails, there's still a lot of benefit of doing it, attempting it, and then going with the alternative options that we described. Of course, the problem is cost. However, I would say it's my experience that the total cost of this procedure is not significantly higher with than like the simple extraction and a little bit more. I think it's definitely cheaper than implant restorations.
I see. Thank you for that. Any questions for Dr. K? Anybody had any similar experience, any similar cases that you would like to share? And I see everyone thanking you, Dr. K, for the presentation. That was really great.
Thank you for the opportunity to be here.
Well, everyone thinks about comments, questions, experiences that you would like to share. I have one more question for you, Dr. K.
Of course.
Are there any common misconceptions about autotransplantation?
Yeah, I would say the first misconception is that it's this crazy procedure that more likely will fail. And as we saw, literature proves that it's not even very technique sensitive. One of those teeth, I'm not going to say which one, out of the ones that you saw, actually during implantation fell in the oral cavity. We had to pick it up from the oral tissues, and it still performed perfectly fine. So the body in biology is amazing that way. The second misconception that I've heard quite a lot is that endodontic treatment needs to be performed before implanting the tooth or immediately during the implantation surgery. And it used to be back in the day that they would remove the tooth, do the endodontic treatment extraorally, and then implant it. Even in cases that the apex is not closed and we know we're going to need the root canal treatment, performing it extraorally maximizes the extraoral time and also makes it impossible to preserve the PDL cells. So research shows now that immediate implantation is the most ideal solution. And then if the tooth needs endodontic treatment, it needs to be performed 2 weeks after the surgery. So I would say these would be the main two misconceptions I hear a lot about autotransplantation.
Any comments, questions before we close the session for Dr. K? All right. Julio, if you could please share the slide. All right. Thank you so much. Thank you to everyone for joining us for this 22nd Denteco, and also to Dr. K for a great and informative presentation. Please complete the post-session survey. The link, I believe, Julio will be sharing in the chat. And we hope to see you in 2 months, in November, for the next Denteco. Thank you again. And thank you, Dr. K, for dropping your email. If anybody has any questions, please email Dr. K. And thank you again for everyone for joining. Thank you and have a great rest of the day.